talk about some work that I've done in collective intelligence while at MIT Center for Collective Intelligence. In fact, we were looking at very big policy problems like trying to solve climate change through the MIT Climate Collab. And I, in particular, looked at this issue with public policy making, which in fact has very interesting characteristics. When we think about public policy, it is a set of rules that are supposed to help a population. And somehow these rules are defined by a group of people, government in particular, with the assistance of experts. And oftentimes in a developing context with investors who somehow are going to finance the changes that are going to be enable public health, better public health for the population. However, one of the bigger questions we had this morning, in fact, had to do with the expertise that participants, in this case, the beneficiaries of these policies, citizens, individuals, are they really experts? And for once, it seems that people, individuals, actually are experts at how they perceive healthcare that they receive or don't receive. So, in fact, there is very much room for understanding what each individual really needs in terms of healthcare that we don't have a good mechanism to grab. So there's a disconnect between big standardized policies for everyone that have been made in a closed decision-making environment of government experts and financiers that actually somehow individuals like us, all of us, could contribute towards. There is literature that discusses this issue in this closed approach to health care priority setting. What is important to prioritize? In fact, it is said that there are biases that are introduced by the fact that there's few decision makers in that process, a closed process. In fact, it comes down to this issue of bounded rationality. It is very hard for a central decision maker to be able to have all the information necessary to make a timely decision of this big magnitude of a country. And in addition, people have been claiming, like I've heard this morning, you know, we need to do more of this citizen science, we need to get more involved, people are really wanting to participate, and that has emerged as a result of new technologies being introduced. Somehow, this is not new either. It's the process of creative destruction that now is invading this field of health. And this very nice work by Topol in the creative destruction of medicine. So, in particular, this study is trying to test, the main goal was to test, could we somehow use crowdsourcing, use the wisdom of people to define what these policies or priorities could be. So the collective intelligence of people was tested to see, by comparison to what we have. Part of what we have is data that typically comes, the most reliable source, from census data. We use that once in a decade. In this case, I'm illustrating the case of India, which is where we conducted the study, and there were many studies performed in different ways, where we're just comparing. In fact, the response that we've gotten online is very close in terms of where we're getting these insights, a good spread of geography that suggests that maybe there's an opportunity for doing things differently than once every decade. This work, in fact, was inspired by earlier work by Professor David Bloom at Harvard School of Public Policy, where essentially they were looking at trying to combine heterogeneous sources of data into what was called the Antares matrix, an econometric model that would embrace open sources of data and institutional data in order to make better assessments of the policies that are appropriate for a given population. So when we met at a conference, it was kind of a discovery, thinking, he figured that governmental policies were disconnected relative to individual states' needs. And maybe that could trickle down to individuals, members of society. So that fostered the idea that instead of relying on say, traditional metrics coming from the World Bank and other sources, institutional, we could actually use a social platform and try to use crowds as a source of data to inform potential public policies regarding health. Now, we all are aware of our own health needs and the problems that we face. That said, there was a little structure already in place, a set of 5 strategic priorities, which I'll describe later, which is the Antares star. 5 out of many other potential factors that have been studied, and these 5 were retained as being the key determinants of a public health policy. So this is the focus of that study. We asked specifically to people, individuals like you, what do you think should be the priority for your government on treating diseases? The answer was, I think government should prioritize the treatment as follows. And they had the opportunity to distribute 100 points. Now, the interface doesn't really matter. We also played with interface aspects. But essentially, there were these 5 points. Scale, as in, is this a disease that is widespread or a main source of death? Is it important for you? Is it important to you where you live? Versus, would you rather prioritize things that would affect your household income, somehow preventing you from being able to satisfy the needs of your local constituency? Or social equity. Should there be preference given to children or the poor as opposed to the general public? Should we, in terms of cost effectiveness, be able to focus on existing solutions rather than looking for completely new or importing new? Should we use existing infrastructure, like existing hospital networks, to deliver healthcare mostly? And spillovers, in the sense that somehow people may be stigmatized with disease and their community prevents them from actually living a normal social life. So these were parameters that had been identified in earlier studies that we now tested through our own method, through crowds, by giving 8 random combinations of these 5 factors of questions for individuals to assess. For example, in this case, I would take 1, 2, 1, 2, and 2. That would be one combination. Then we take another random set of combinations to measure these 5 dimensions, and we're trying to figure, can we come up with a reliable answer from people? Even if the questions vary a little bit, are these reliable? That was the main goal. Can we come up with this tool? And we ran this survey. I'm just giving you the survey insights, where we actually had 3,000 plus individual pieces of data that people have returned to us in their assessments that we could then process into what we call these healthcare priorities. We control, of course, for demographics, like all studies in development, in order to determine if, of course, there are differences at the individual level, which we don't particularly want to focus on, but rather at the aggregate level. And in this particular case, we're looking at whether location, which is one of the main sources of insight from existing studies. Rural areas have different needs than urban areas, and so on. So this is what this first study focused on. This is what the results look like in terms of how people prefer things. So the people in general are focusing on scale, which is at the top, and social equity. These are the 2 things that people somehow prefer over other things. And when we look at the statistics, we actually are very happy that the reliability internally of these different variations was pretty consistent. So people didn't get completely confused and answered at random. Actually, they answered very consciously and focusedly on, my priorities really are more like this. And regardless of what combination of questions we gave them, they still did provide the same information. So that was very good. And then we observed that when we look at the population with high income, this distribution looked differently. As in, scale was more important to people with high income. And when we looked at other things that were important, like, you're from a rural area, the difference doesn't seem to be that big. So we don't really see any difference, which is why it was so important to actually do statistical analysis with this, which is what we did next. So through thorough statistical analysis, what we're trying to doing is, these can't happen just by chance. can we, controlling for demographics and running simultaneously, still claim that we actually see these differences? And the good news is that when we look at income, it clearly is there and consistently helping us understand that people with high income indeed prefer scale more. So prefer prioritizing diseases that have widespread effects on populations. And the rural areas have a negative effect in the scale of disease, which is actually much bigger than we could see visually, controlling for all these other parameters, which is a very nice insight that is unfortunately not new. Now, this is something that we knew from econometric analysis. What is interesting that is new is that now we could see that actually some other factors like the number of children as opposed to the size of your household was really important in how people perceive their preferences in terms of healthcare priorities. So this insight is something that was backed by what people were telling us. As an Indian and a medical professional, I am very happy with this survey. Thank you very much. Great work. If this helps standardizing the policies and forecasting requirements, it would be great. I am concerned about the healthcare scenario as it is unfolding in my region. I would be glad to contribute with my inputs if it can help my family and my community. So people were actually truly involved with the research, and 95% of them would like to contribute regularly. That was really tremendous news to get as additional feedback other than the statistical analyses. So now, to us, what's really interesting is that this collective intelligence approach proved to be pretty fast. So every round, every iteration of data gathering took 2 weeks. Simple and effective. You know, it was consistent, it always worked, which is what we proved statistically. So that was really good news in terms of we can reliably obtain similar results with different populations at random. Now, what's most important ultimately is that this approach unveiled new systematic differences in how population prioritizes competing public health priorities, policies. So now we know that children count is really important in how people will express their needs, in addition to the other things that were more traditional, like income level or geolocation. Most interesting, like I said, this open public health policy process is something that people welcome. And we're just wondering, why haven't we been doing this more? The total cost of the study was less than $10,000, and a similar study would have costed $2 to $3 million to do in the field. Now, what's more is other insights from this research, because we wonder, you know, people that have voted are those who have representatives in government that would set policies that probably affect them in different ways. A lot of the effort is to realize if you are from a given party amongst those that voted. The question that is not represented in the literature is one of, what about those that did not vote? Is there any difference? And interestingly, we don't know much about that, and what we run in the study was this question: did you vote in the last elections, national elections? And as it turns out, it is very strong. So people that did vote have a strong preference for their household finances, whereas people that did not vote have a strong preference for social equity. So the representativeness of the group of decision makers that come up with public health policies somehow is biased by the population that has elected them to those positions also. So this really brings up a whole new area of research in saying, you know, how can we do this better? And the very simple, you know, reason comes to the very fore of this presentation. There is this bounded rationality issue where we have very little information in the hands of decision makers to make up the best, most optimal decisions for these very, very all-important aspects of our society. Now we have an answer. Partly comes from the effort at Harvard, the Antares project, with open data and existing institutional data. We can analyze that, big data analytics, that's great, but it's static. What's new thanks to this study is that it's dynamic. You can do the same thing every time in a couple of weeks, get the same and better results because they are results you can get over time at a much greater frequency than the 10-year periods that we wait for the massive census data to come. I would love to hear more from what you think about this, and I would love that some of this could actually be implemented in more places than, say, the context of the Indian development efforts. Thank you.